So in this video, I would like to explain about the exact opposite of diabetes insipidus, that is SIADH, syndrome of inappropriate ADH secretion. Here the problem is, in the diabetes insipidus video, I have already told you that what is the function of ADH in our body. Here, because of increased secretion of ADH hormone, what will happen? There is increased water absorption in the tubule. When the water absorption in the tubule increases, it leads to expanded plasma volume. As a result, what will happen? There will be natriuresis due to suppression of renin and aldosterone. Okay, so as a result of this, there will be decreased plasma osmolarity, there will be decreased sodium in the plasma, okay, leading to a condition called as euvolemic hyponatremia. Why? Because here the volume, okay, the plasma volume, even though it appears to be expanded, okay, per se, value wise, the total volume remains constant because of the RAS mechanism. That is the reason we say that SIADH is an example of euvolemic hyponatremia, okay, because the volume remains constant but the sodium levels fall, plasma osmolarity fall. So when the sodium and plasma osmolarity falls, what happens to the urine sodium and urine osmolarity? It automatically increases because of the natriuresis, because of the suppression of the renin and aldosterone. Okay, yes. So coming to the causes of SIADH, remember the most common causes are CNS associated causes, okay, that is head trauma, head injury, okay, subarachnoid hemorrhage. Even is following an episode of stroke, the patient may have a compliance of SIADH, Guillain-Barré syndrome, multiple sclerosis, okay. Then tumors, small cell carcinoma of the lung is very commonly associated with SIADH. Even viral and bacterial meningitis are known to cause SIADH. And of course, drugs. What are the drugs? We have drugs like chlorpropamide, okay, anti-cancer drugs like cyclophosphamide, vincristine, tricyclic antidepressants, okay, vasopressin, okay, because vasopressin is used in the treatment of diabetes insipidus. When the dose of vasopressin exceeds the normal dose, the patient may present with SIADH. But still, if they ask you what are the most common causes, head injury, head trauma, subarachnoid hemorrhage, small cell carcinoma of the lung, and drugs. So these are the various common causes of SIADH. So as far as SIADH clinical features is concerned, I told you that hyponatremia happens. So what is the normal serum sodium level? It is 135 to 145 milliequivalent per liter. Here there is hyponatremia. So because of the decreased sodium, there is a fall in plasma osmolarity, and simultaneously there will be an increased urine sodium and increased urine osmolarity. Okay, yes. And remember, because of the plasma dilution, the uric acid level as well as the blood urea nitrogen level also tend to decrease in SIADH. Okay, this was a previous MCQ. Which of the following decreases means when the blood urea nitrogen level, serum uric acid, all those occurs low. But remember, even though I am telling that there is plasma expansion, the RAS mechanism won't allow hypervolemia. Okay, it will maintain the volume status of the body. That is why SIADH is an example of euvolemic hyponatremia. Okay, and as I told you that there is increased urinary sodium, that is more than 30 milliequivalent per liter, and the characteristic diagnostic test is what we call as a water loading test. That means we will ask the patient to have drink a lot of water over a period of some 12 to 24 hours, and after that we will see the amount of sodium which is excreted in the urine, or we will see the urine osmolarity. Okay, even after giving water loading test, the urine plasma osmolarity remains elevated, we call it as SIADH. Even after giving water, if the plasma osmolarity, the urine osmolarity remains elevated, or the urine osmolarity fails to get diluted. Usually on taking more water, it has to be excreted now. Okay, so the urine become more dilute, but here urine fails to get diluted. That is why it is called as a water loading test, and the test is negative, means it confirms SIADH. But the classical or the most specific test, if somebody asks you, go for serum ADH levels. And as far as treatment of SIADH is concerned, what is the best line of treatment? Always do water restriction therapy. If the patient does not settle with the water restriction therapy, we have to go for, that is we call it as chronic SIADH. We have to treat with the anti-ADH drugs, that is either democlocycline, okay, which is a tetracycline analog, or we can go for conivaptan, tolvaptan, which are nothing else but vasopressin, V2 receptor antagonist. Okay, yes, conivaptan, again it is a much more effective drug, okay, than the rest of the drugs. And as I told, they are vasopressin, V2 receptor antagonist. V1 receptors are present in our GIT, okay, blood vessels, vasoconstriction. V3 receptors are present in the pituitary, and it is V2 which is present in the kidney. Okay, so these are the important points you have to remember as far as SIADH is concerned.